Hello, Robin. Welcome to our show today. It's so nice to have you on.
Thank you. Good morning, Erin. Good morning, George. Thank you for inviting me. I'm very excited and honored.
Yeah, we're super happy to have you. We have with us today Robin Kempner, who's the Director of Behavioral Health here at SohoMD. So we are very excited to speak with her today about trauma.
Hopefully it's not too traumatic. The listeners are able to get something beneficial out of today's meet. But yeah, welcome to the show today, Robin.
Thank you, George. Yes, I'm hoping nothing I say will be traumatizing to anybody.
Well, I guess let's just start right there. How would you define trauma?
So, over the years, that's definitely morphed. When I first became a therapist in either 90 or 91, nobody talked about the word. Like the word never came up. It was never in an interview with a patient. Clients never just said, "Hey, I experienced so and so." And then in the early couple of years, we started asking, "Have you ever experienced trauma?" And in those early days, I know what we meant without saying specifics, but what I call, and a lot of people in the field call, like big T traumas, meaning the abuses, right? Like physical abuse, sexual abuse, emotional abuse, um, and it over the years, as we're learning more and more about simple trauma, complex trauma, the realization that PTSD is not the only type of trauma, things have really become more like fully, I guess, defined and much more inclusive. Because I think the definition of trauma changes depending on the person who's having the actual experience. I give this example a lot to the patients that I'm working with. So if George and I are on the street together walking and we witness a car accident, we're both seeing the same accident at exactly the same time, but I may walk away from that and not be able to stop reliving that. And weeks go by, months go by. I'm having increasingly difficult time even getting in a car, crossing the street. Sounds make me startle or jump. And George, like after a day, is walking around like, what? Like, yeah, I saw that, and told his friends, hey, guess what I saw? And it was terrible. But then that was it. So it's my experience how my mind literally interprets the emotions that I am experiencing at that moment. So if my mind says, "Oh gosh, this is more than we can handle," your mind makes this like shift, and it kind of gets stored away so that I can go on and manage. It becomes like a more, I'm using air quotes, formal trauma diagnosis is when a significant period of time goes by, and anytime I now hear a loud noise or I'm about to get in a car, my heart races, I get dry throat, my stomach starts to hurt, or I just can't do it. And it's years after. That's how we know this is an unresolved trauma. So I think the people that we see in our practice that exhibit maybe these life disturbances in some way, we often look to see if there's some type of trauma. So I know that's a very big answer, but categorically there's the big T, and then there's also bullying, right, which we talk about all the time, and the long-term effects. Again, being in an accident, witnessing an accident, being a part of a natural disaster, a fire, it it sometimes can be tiny, simple little things, and it's so dependent on how that person receives that information and then how their mind and emotions together interpret it.
When we think about trauma, I think what you mentioned, the big T, right? That's the first thing we think of is the big T, the big event, the thing that happened. And I've noticed as a clinician myself that sometimes when I'm asking patients about trauma, they'll say no, and then later on we find out, oh, certainly there was trauma, but it didn't maybe fit the big T category. So I'm curious if you can like explain a little bit more, because I'm very familiar with the big T, small t. We use that terminology a lot,
Mm-hmm.
but perhaps for someone who's never been in treatment or is not a clinician, they might not be familiar with that terminology.
So big T would fall. We use it to categorize or denote someone that has an experience or multiple experiences of physical abuse, and that can be by, and this is predominantly occurs in early childhood, uh, early adolescence, and into adolescence. We see an impact of it vary depending on what point in their lives the trauma might have happened and what happened preceding the trauma. So physical trauma could be perpetrated by a family member, a friend, a caregiver. Same with verbal abuse, emotional abuse, and psychological abuse. Um, Emotional abuse happens, I think, more often than people realize, and not always from the bad parent, like a parent that is deliberately cruel in some kind of way.
Yeah, like
Sometimes
says
parents,
nasty things or calls them names. Yeah.
right? Sometimes they'll just say like, "What are you, stupid?"
Hmm.
And maybe never have said that before, and maybe we'll never say it again, but that's what the kid remembers. That stays stuck with that experience and then goes on to impact their sense of self, their capabilities, their confidence, their esteem, all of that. And it keeps going. And then it just keeps growing from there. And then there's sexual abuse. Again, can be perpetrated by anybody. Doesn't have to necessarily be a family member. It could be an extended family member. It could be a friend, a neighbor, a babysitter, a teacher, a classmate, which I think people don't always think about. And um, it's not always also intercourse. Like
Hmm.
penetration does not have to happen for an sexual, pardon me, trauma to take place. Sometimes no touching takes place at all, and yet the trauma is very significant. Um, so those would be the big T's, right?
Right.
Like the ones that I think, like you said, like even when we ask a question in an initial interview with a patient, I'll say,
Hmm.
hey, do you have any history at any time in your life of any trauma? And let's say no. And then I clarify and I said, I'm not talking only about the
Mm.
ones that we just talked about. I'll say, for instance, have you ever experienced being in a car accident? And they're little t's. And little t, we should not confuse it as meaning not as important or not as
Right.
significant
Right.
or not as debilitating, because they all are on the same level playing field. Level playing field that
Yeah.
way. So that's the bullying, the name calling, and now unfortunately, as we know, kids that survive school with gun violence, which is
Hmm.
happening more and more. So things like that.
So, Robin, I'm curious. You said that like earlier in your career, you guys were addressing, as clinicians, more of the big T sort of traumas, but over the last couple of years, it's been like broadening. Do you feel like there was any particular instance in like the community that brought light to this, or was it just a matter of over the years, clinicians refining, identifying certain triggers and things in patients, or do you see like there was like a point where things started to change?
I think it's a combination of all of those things, to be honest, George. I think that uh, when I'm going to assume that when patients started talking maybe a little bit more, especially younger, about being bullied, I mean, I I can tell you, like, from my generation, we never told our parents. Like if I got picked on in the schoolyard, if I got into a fight, I would never tell my parents ever, even if it wasn't me, because I was afraid. I think when people become more informed and we learn more, and then we hear it more and more and more, it just has like that reverberation, and it starts going out. And then I think from the psychology and psychiatric community, then we start doing research and start seeing and measuring and looking at, oh, so this kid who maybe was always picked on or made fun of, this is how their school performance changed. This is like symptoms of anxiety that was showing early on, but nobody picked up on it because nobody knew. And now we have maybe a socially anxious kid who's very, you know, fearful, terrified sometimes of meeting new people, because in their head they can still hear the voices, right, of the bullies saying you're small, you're worthless, and all that. So I think once research meets what's actually going on is when then we can learn then what helps. What can we do as practitioners that can potentially make a difference across the board with all of these things? Because I think from a symptomatic point of view, they share a lot of commonalities, meaning if the trauma came from physical abuse or the trauma comes from surviving a fire where you've lost everything and you watch your home go up in flames, I think we see the anxiety, the fear, this hypervigilance, this startle, like all these things cut across what the initial traumatizing event was.
Yeah, that makes sense. I'm thinking, I know we're reading that book, The Body Keeps the Score. And
Yeah.
as George was asking that question you're answering, I'm remembering there's a certain part where he says, oh gosh, maybe it was the 70s he was referencing, and he's like, the books say that 1 in a million, I'm kind of making that up, but it's like a very small percentage of women is sexually assaulted. And he goes, and I have 40 of them on my caseload.
Yeah.
I have all of them on my caseload.
Right.
And so it sounds like, and maybe you've had some experience with this as well across your career, but that certain trauma, maybe one, like you said, it wasn't talked about. And then two, it maybe wasn't even considered traumatic, or like you said, it kind of unfolded over time that, yeah, these are also very traumatic events, or they're very underreported.
I 100% agree, and that is hysterical. It's Bessel van der Kolk. That's his book, and when I read that, I had to laugh because I feel like we've all been in that situation at one point or another. Like, okay, those statistics cannot be right. So I do think, especially in the earlier days, like I was saying, the practitioner, the professional, didn't ask. That question wasn't even asked. And not because we didn't know trauma existed or that at least these things were happening, but it was so often from a societal and cultural point of view.
Yeah.
Like, oh no, this is like for families, okay? Like, no. Even a professional we ask a patient everything when we do the initial interview. But I think there was a mindset of that's crossing the line. And because it was kept, especially sexual abuse, was kept so tight. I mean, look, mental health was kept so tight, right? I mean, I remember growing up, I had, an uncle that was, now I know, severely mentally disturbed, but I remember like my grandmother saying, shh, don't, nobody talks about that. And I feel like that's true, and especially with trauma. And kids didn't say for fear of not being believed. Schools, like now, think about it, right? If a kid goes into a school that has a cut or a couple of times something seems to be wrong, the teacher reports it. We have mandated reporters now. It was like the polar opposite in those days. Everybody had a zipped lip. It was not proper. And I think culturally, I have to say that when it comes to women, and I did hear this a lot in the beginning and still hear it now, I don't mean to make it sound that I don't, is that it was my fault. Like I would hear over and over, like I was 10, I was 9, but I made him do that. And you could not, there was nothing I could think to say to a patient that said that to me at that time that would help them see, okay, that's just not possible. It is impossible. But that's, I think, what women came to believe. Like, why did you dress that way? You were acting too cute or something. So again, then why would I report it? Why would I tell it to anybody? So I think it's about cultural changes, making mental health in general a topic that's put out there and spoken about more publicly, removing this, it's what's in the family stays in the family kind of thing, and removing some of the shame on that level. Because unfortunately, there's already a lot of shame that the victim or the survivor, I like to say, has to deal with, even
Mm-hmm.
without all that.
Yeah. And so how might you recognize trauma, and maybe more of like not from a clinician standpoint, but like as a person, if I might have experienced trauma, how do I know that I'm traumatized?
Um, I don't know that anybody would ask themselves that question. I, I think people know what they've been through.
Mm,
Okay, not everybody, right? For some people, the memories are deeply, deeply locked away, and they really don't remember it all. And if I would ask them, they would swear up and down, no way. But we look to other things that are going on in their current life, right? We stop asking about the past and we ask the person, like, take a look at your life now. Are you having any issues or difficulties that you find are interfering in some kind of way with your work life, your relationship life, your friendships, with your health, anything? Because that's how it shows up. When somebody can say to themselves, I don't know, like I keep seeming to have the same thing happen to me over and over again. Or I can never seem to shake this one feeling of like this pit kind of in my stomach before I go to work or before I have to go see my cousin or something. It's really paying attention to your body. I have to
mm,
say that our body tells us so much, and we are so trained, especially in America, to totally ignore our body's signals.
mhm,
So I feel like we would find out things so early on if we listen to our stomach aches, or if we listen to our heart palpitations, or the tightness in my throat, or this sense, right? People say, like, I had this sense I was being followed. Yeah, well, sometimes you actually are being followed, or you're having a trigger that's reminding you of being followed, of someone
mhm.
being behind you. So I think listening to your body is a very, very important thing.
Yeah. Yeah, because sleep is also a big thing that's affected by trauma. And I'm thinking, like, when I ask that question too, that sometimes people might, like you said, ignore certain signals that their body's telling them. Maybe they're like, I'm fine, like that didn't affect me. But and maybe on a certain mental platform, like day to day, maybe we're white knuckling it or something like that. But these other signals, like you're saying, these body signals could also be an indicator. And so yeah, sleep is often commonly affected as well.
And I think because it's not unusual for people to have persistent nightmares, right?
Mm-hmm.
So, and very, very vivid. You
Mm-hmm.
know, when people, uh, and it doesn't necessarily have to be a nightmare of a traumatic event. That's not how our mind actually works. Like, it doesn't replay things like, oh, you just rewound the movie and now you're seeing the whole thing in context. It can show up in these other ways where, maybe I'm running for my life, or maybe I feel like I'm drowning, and or somebody I care about is being hurt in some kind of way, but they're vivid,
Mm-hmm.
and the emotional experience is real. And often I hear that the emotions mimic the emotions experienced in the person's traumatic event. So when they wake up in the morning, they're soaked, and sometimes they're disoriented a little bit, not sure exactly where they are. But that is not at all uncommon. And you may not have any other symptoms, like outwardly, And if you're a person that's had nightmares for a long time, why would you think maybe this is not normal? Like, does everybody have these nightmares? I think like that's what you're saying too, is that if you had something that happened to you in your young years and you made adaptations to
Right.
manage
Mm-hmm.
maybe the anxiety that came from that and the persistent now negative thoughts that you have, which further drive your anxiety,
Mm-hmm.
but I still have to go to work. I still have to take care of my family. I still have to whatever. So
Yeah.
we find it's wildly amazing. We find these adaptations, but in doing that, we
Mm-hmm.
start to, I hate to use the word normalize, but like we get so used to it.
Yeah.
Like this is how I feel. So if I ask you in an interview, like, are you feeling these things? You may say to me, no, like it's my regular thing. So why am I reporting that? If that's what my baseline is, if my baseline anxiety is 8 every day, and I ask you, do you experience anxiety or spikes in anxiety? Why would I say yes?
Right.
That's all
Because you
I
don't
know.
know any different.
Yeah,
And so
that's
I guess, and that's a really good point because we did want to talk about too, like traumas that happen in younger years.
hmm
What tends to happen if it's maybe pre-verbal or like in those younger years where they don't really, the brain maybe doesn't know how to exactly process the way an older person might be able to, even an older child might be able to process a trauma.
So pre-verbal trauma is still stored in the brain, right? Because visually we still see. We don't have words, so we can't categorize and catalog, in a memory in that way.
Right.
However, our other senses are in full bloom, so to speak, right? So we feel everything. And if you think about like an infant, right? Let's say below the age of 2, although this happens later, they're working on survival instincts, right? Feed me, clothe me, keep me warm, change me, and show up, right? They're looking for consistency so that they begin to understand, like, I don't have to worry. I'm not going to starve to death, freeze to death, or be left alone unattended, right? So it's really just about survival. So things get stored as anxiety. I know I hate to say it because I think when I tell this to people I'm working with, they look at me like, okay, no, you're crazy.
Mm,
But no, I mean, think about it, right? If you have an infant and let's say you have a parent with a mental health issue or a substance issue or has difficulty parenting for whatever reason. So they show up to feed and change the baby regularly today, and then the next day they never show back up. Then they come the next day, right? So they're there and then not there. So this just drives anxiety. It is literally fear for your life. So it is the earliest like flight or fight. Like what do I do? So I feel like when we talk about pre-verbal, that is how they feel. So if working with people that have maybe pre-verbal, that's you'll be. I think we could expect to hear more sounds and physical sensations than I remember blah 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 happening. It'll be like in let's say like during EMDR, which is a very well researched method of psychotherapy that helps the brain like unlock and reprocess memories. So, but not everybody has words for everything. And look, even people who are older and have a fully developed brain in that kind of way, meaning that they can speak and they have memories, they don't necessarily remember anything anyway. It just depends, right? It depends what the brain did to protect itself, to protect me.
yeah, you mentioned EMDR. Can you tell us a little bit about EMDR, EFT, these more like non-talk therapy rooted modalities?
Yeah, and it's really amazing. And this was all new for me to learn over the last several years. I'm an old timer, so I, practice using many popular methods, which are still worthy and worthwhile. But EMDR, it stands for eye movement desensitization reprocessing. And it was created by a woman named Francine Shapiro in the late 80s. And it's a way that helps people heal from trauma that's kind of locked. Like if you think about it, like it gets locked and it's there on the key, right? And it happened a long time ago, and the emotions, instead of being locked with that original memory, the emotions get separated from the event and get locked away separately. So now this has been an unaddressed memory and unaddressed emotions. So I keep holding on, and then things keep happening, right? And every time I get triggered, meaning every time, I don't know, a sight, a sound, a smell, a look, a word, triggers my memory of something that happened back then. My amygdala says, it's happening now, it's happening now, it's happening now. So you get these big motions as if that original trauma was happening present day. So EMDR uses bilateral stimulation, meaning they do tactile, meaning touching, but predominantly they do with this eye movement, right? So if you're in person, you're following the practitioner's fingers. With us, we use something different that there's a program that we can use online. So when we're doing video sessions. And it's in that eye movement and the speed of the eye movement while they're holding certain images that we've discussed in advance, that it starts to bring up these negative feelings, thoughts about self, connecting it back. And it is the repetition of this process that ends up putting the emotions back with the original memory, removes this negative views of self, puts in a positive replacement instead. Then you get more bilateral stimulation, and you hold that positive, and then you start to realize, oh wait, I'm thinking about that thing, and oh, I don't feel like I want to throw up. I don't feel anxious. I do think I'm worthwhile, or whatever the positive thing. Like that seems like a true statement. So EMDR, I mean, it is, I believe, the number one recommended method for PTSD with veterans. I think they've been using it probably, I think as a big group, maybe the longest. And it's like this, if you just give me just 1 second, because this was like a little analogy or a metaphor. So if you think about how, like, sorry.
It's okay.
If you get a cut like on your hand, let's say, right? So the body works to heal that cut. But if I keep hitting it, or if I get dirt in it and it gets infected, that never closes. That's what it's like. Having unresolved trauma is like having this wound that never quite closes. And EMDR works to remove all of the stuff out, clean it out, and then whoop, and then everything closes. And it just becomes a memory that you have. It doesn't erase anything. A lot of my patients ask me, will I not have that memory? No, you still have the memory. It'll just be, though, a memory from your past, something that happened to you. It won't have that emotional impact, dysregulation, or interruption like in my life. Like it's no fun to walk around when you don't know when you might be triggered. There's also the emotional freedom technique, EFT. There's two EFTs, but this one I'm talking about is Eft Tapping, which involves also physical. Like, I don't touch anybody with EMDR, and I don't have to touch anybody with EFT tapping. You would follow along with me. And it's really based on acupressure points. And incorporating, again, a positive statement along with the tapping. And it phenomenally works. I wish I could completely understand why it works, but I don't. I understand that it's acupressure points, side of the hand, head, here, 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 here. Okay, tapping, tapping, and you repeat along. And somebody's level of anxiety, like I've seen it drop. If 10 is the highest level of anxiety, I've seen people tell me at the beginning they're like at an 8 or a 9. And then after several rounds of EFT, they're like at a 4 or 3.
Mm-hmm.
And, that's a huge difference when
Huge
you're
change.
experiencing the physical symptoms of anxiety.
The first time I ever heard about EMDR, I was fascinated. I was completely like, and I'm not a clinician, but I was blown away by the idea, and it's to me it kind of sounded like a hack, like you're hacking your brain. You're understanding that there's some issues going on, and you're using this method to hack. But my question to you, Robin, is what were your first thoughts when you kind of heard about this for the first time? And then also, have you noticed any reluctancy from like the psychiatric community bringing these techniques into the home base?
It's so funny because I had actually heard about EMDR like maybe 15 years ago, and I remember exactly my face. That's what I did. Like, yeah, okay. When you come back from Fantasyland, let me know, right? Because there was nothing, right? At least that I knew about. And look, I'm not the most well researched, well studied, well versed therapist because I'm a therapist. I'm not a researcher, but I really just thought, yeah, it just sounded like mumbo jumbo to me, honestly. And then, people started talking about clinical hypnosis, and then, everybody does the same thing. Oh, you're going to make me be a chicken when we're in session? People always ask that. Are you going to make me cook like a chicken? No, and that's not how hypnosis works anyway. But, and when I was working in Florida, and I won't say where and I won't say with who, somebody I was working with had become trained in clinical hypnosis. And this was an all women's program. And he worked with one of the young women there, and I watched and her go through this trauma. And it ended up being okay, but it made me nervous. It made me nervous to see what she was going through. And I think, when it comes to trauma, for a very long time, George, the belief was the only way to resolve a trauma was to relive it, to totally relive it. And who wants to do that? Right, exactly. Like, who would willingly go in and say, okay, I'm going to sit now with you and yeah, no good. So I didn't know how I felt about all these things. And then about 4 years ago, I was reintroduced to EMDR from an article that I had been reading. And then I thought, oh yeah, this thing. And the more I read and the more I understood about the brain, which again, not a scientist, not a doctor, so didn't have a lot of knowledge about the brain. I only knew about the prefrontal cortex because I worked many years in addictions and heavy focus in that area of the brain. So when you really learn about the brain and how the brain can actually heal, oh, you can heal from these things. It became more plausible in my mind, and I became much more interested. And then I just started reading more and more. And I feel like the psychiatric community and the medical community is really catching up to it. I feel like even if though like other people believe that it could work. Just from a personal point of view, as a therapist, like I've been a therapist since 1991, and learned lots of things and kept growing. But when I took the training for EMDR, I remember coming out of that training and saying to Dr. Joe Petrie, "Yeah, I don't think I can do this." It scared me because it is so different that it required me to literally take everything I know and put it over here while I'm doing this. It is completely different. But I do feel that there's so much research on it now that anybody who maybe would laugh at it or scoff at it as, like new age junk or whatever. Can I say crap? Crap. Um, there's too much research now to point that that is just really not true.
Well, what are some tips or like best practices you would give to someone, someone speaking to someone that is like expressing their trauma to them? Like, what are some tips that you could give them to make them feel more comfortable, express, feel confident?
I feel like it's always my role, whether it's trauma or not, to ensure that the person I'm working with is empowered during the time that we're working together, right? I want them to know that they are in complete control of the session, meaning they can say what they want to say, not say what they don't want to say. They can stop at any point. They can change the topic at any point. They can scream, yell, cry, laugh. They can stand up and pace and walk around, whatever they want. They can come to session and say, and this happens many times, especially when working with trauma, where I don't feel like working today. I'm like, okay, right? I don't direct the session. I do not. It's not for me to do that. Trauma informed care, right? That's what we all want to do, whether you're a clinician or not. Trauma informed care became a well practiced and now best practice. I guess it was in the late 90s, early 2000s. And this was something that we all were getting trained on, meaning just the way that we communicate with others, especially in the treatment world, has to come from a place where you don't know what someone else may have gone through. So watch your tone, be pleasant, be kind, take it easy, don't push. If someone says no, respect no, try and explore like how you maybe help them to do something that they need to do that they're having a hard time doing. It's just acknowledging that none of us know, right, what somebody has been through about anybody, right? We don't know. So I feel it's very important that when people decide to come to therapy, that they understand that that time in therapy is 100% theirs in every way, shape, or form. Apart from hurting themselves, then I have to take direction. Apart from threatening to hurt themselves or someone else, then I have to take over. But when it comes to how the direction a session may take or not take, I don't ever go into an appointment with somebody thinking today we're doing this. I may have an idea based on what we met last week, but I don't say, hey, we're doing this. I wait and see what that person brings that day. Because that's always the important thing, right? What's happening on the mind in the moment is the thing that I find makes the session more successful. Instead of like, oh, remember last week when we were talking, can we pick up where we left off? Well, we can, but the person needs to know that they're empowered in that session, even if they don't feel that anywhere else in their lives at that time. In that session, they have that kind of power over themselves and how the session goes.
It's very well put. Just empowering the patient, giving them the confidence, and then they'll take it from there for the most part.
I just scared myself with that. I sound like some kind of sage or something. I'm like, oh my gosh.
I thought it was awesome. Thanks for joining us today, Robin. This was really, really insightful. Yeah, you just know, so you come with such a background, diverse background, years of experience. So I really appreciate you coming on and sharing some of that with us today.
I hope that I was able to give anybody that's listening also some information and maybe some direction forward in some way for them. So yeah, thank you. I so appreciate being invited.
Awesome, Robin. Thank you. All right, Erin. Thanks for this episode, and see you guys next episode.